Hi, Assalamu alaikum, and a very good day. So for today, we'll have a lecture on patient positioning and immobilization. So this is one of the important aspects in radiotherapy, in which it's the start of for a simulation to be done. Then you need to be able to know how to correctly position the patient and use all the available immobilization device to make sure that patient will stick still for at least 25 to 30 minutes per treatment time. Okay, so what is positioning and immobilization? So it's basically how we establish and maintain the patient so that they will be in a fixed and well-defined position for at least 25 fractions, okay, for a single patient. So we would like to immobilize or make sure that patient does not move at all. So this is the thing where we can do on what we can do to be able to fix a position and for to control the movement that we can actually control. There is some movement that we cannot control. For example, your breathing, your respiratory, and also your bowel movement. So that's the thing that we cannot control. Okay. So the main objective of positioning and immobilization is to actually limit the patient movement, and also when you limit the patient movement, then you will actually reduce the probability of positioning errors, and it will help you to actually do a daily setup, because you need to maintain this position again and again, and it will give an assurance to the patients that you know what you are doing, and it helps in actually to produce a more rigid body position. Okay, so what's the step in patient positioning? First of all, before you put the patient on the couch, what you need to do is you need to prepare all the immobilization device on the treatment couch first, and then after that, once everything already set up, then you will ask the patient to actually sit or stay on the couch. So you transfer the patient to the couch. So it can either be in the supine positions, or it can either be in the prone positions, lateral positions, or in any positions. Okay, and we will then adjust the patient position based on the couch. Okay, so we need to be able to observe, and we need to be able to put a tattoo. So tattoo will be the external landmarking that will help you to reposition the patient every day. Then after that, once the patient is comfortable, then you will need to immobilize the patient using all the immobilization device that you already set up. Then after that, there will be two alignment lasers that will help you to position the patient so that you can align it with the skin tattoo marks on the patient itself. So the first rules in positioning and immobilization is it need to be reproducible. So it doesn't need to be out of the world or something that is not comfortable for the patient. It's not something that we want, okay? Because reproducibility really means that patient can maintain the same positions again and again, and it should be comfortable enough for patient to maintain their positions. And if possible, we actually will personalize the immobilization device for each of the patients. Okay. Okay. You need to make sure that patient should be aligned straight on the simulated table. So this will make the alignment of the patient much easier. And patient should not be rotated or slanted. So that's why after each position during the simulation, we actually need to align the patient. So the alignment of the patient will be taken using the x-ray. So we take the x-ray of the patient. So one of the way is to make sure that patient is straight is we align the spine. So we take the picture and then we see if the alignment of the spine is straight. So it will show, or it will confirm that the patient is not rotated or slanted. Okay. Why patient need to be aligned straight? One of the main aims is so that it can be reproducible, because much easier to reproduce a straight patient rather than a rotated one, unless you are dealing with patient that is having a normal rotation or slanted, like for kyphosis or lordosis type of patients. Okay. When you actually do the setup of the patient, even though it's something that you commonly do every day, but for every single one of patient, you need to realize that each of them is different. So you need to be able to equip yourself with the knowledge on what is the location of critical structures and target volumes for this type of patients. And then, because each of patient is unique, you need to know patients' health and flexibility, because not all patients will be flexible enough. And if there is any implants and any anatomy anomalies on the patients, like if patient have kyphosis or lordosis, then you need to take that into considerations. And then another thing that we need to consider is the availability of the immobilization device, because in some centers they might not be equipped with all the immobilization device, so you need to be creative in that sense. Okay. And when you are actually using the immobilization device, most of the prefix immobilization device will not produce artifact on CT image. But if you need to actually create a new immobilization device, then you need to make sure that it doesn't produce any artifact on the CT image. Okay. One thing that is very important is patient need to be comfortable, and patient need to realize they are in control of it. Okay. Because even though we have a 40 by 40 maximum collimation, but and we try to fit the collimation as small as possible, but it does not help if patient is not stable. That's why it's very important for us to do a very good positioning and use an optimal immobilization device, so that patient will be comfortable as long as possible. Okay. So this is among the immobilization device and the setup that you need to consider. First is the laser. So the laser usually will be used for alignment of the patient for the immobilization, and the second one is the use of the base plate. So this is the indexer in which we fit the base plate on it, so that we can actually secure all the other immobilization device on this base plate. So the base plate usually is very strong, but it have a very minimal attenuations, so it will not obscure the radiation pathway. Most of it is made from acrylic, and nowadays we are using more that made from carbon fiber, because it's much more lighter and easier to be mobilized. Okay, this is one of the important things that you need to consider. So every time you want to set up the patient, make sure your couch has a indexer on it. Okay, so you can actually put it at any place here. So, but you need to make sure that you record where is the indexer position on the couch for every single one of the patient. Okay, most of the time it will be at the same side. But for example, if you are using it for the head and neck, it will be much higher on the couch. While if you are using it for pelvic immobilization, that it will be much lower. Okay. Then you can actually lock it down by rotating the levers. Is at this side, on both sides of it. So they have the levers so that it can be locked down on the couch. Then after that, you can actually put the base plate over the pins. So this is the pins on the indexing bar. So it will help to make sure that the base plate will not move and stay in the fixed position at all time. Okay. Okay, so this is some of the list of the positioning device that we have. We have some of it in our lab, okay, but some of it we doesn't have it, but we have it in the clinical. So we have the hand grip, we have the overhead arm positioners, we have the shoulder retractor and breastbone and prone breast support, and we also have the belly belt. So this is what is known as the neck roll or TMO. So most of the time this will be used for the head and neck positioning. Okay, so this is where you locate the patient head and neck. So each of it has a name to it. So it's actually each of it represent different size. So we have A, B, C, D, E, and F. Okay. So maybe some of the patient will be more comfortable for different size. So each of it have different size. Okay, once you put the patient on the base plate, what you need to do next, especially for the head and neck, usually we will fit the patient head. So what we need to do to fit the patient head so that it will not move is we are going to use what is known as the BDS, beam directed shell, or is also known as a thermoplastic mask. So it's actually a plastic sheet in which we place it into the water bath. The water bath have a warm water so that it become very pliable and it can be fitted into patient's face contour. And then we actually will mold it so that it will fit into the face surface. Then after that we will lock the BDS to the base plate so that it will stay. Okay. This is very common, the BDS, or known as thermoplastic. One of the advantage is actually is about having to draw on the patient face directly on the reference point or setup mark, because you can actually draw on the BDS. But the main concern is because there will be an increase in surface dose because you are increasing the thickness of the radiation pathway. So, but it will depend on the field size and also the location, because for some of the treatment, the area of the treatment can actually be cut up from the mask so that you will reduce the patient separation. Please take into consideration when you are using the mask or the thermoplastic BDS. It needs to be evaluated at least after few fractions so that you will know if patient already lost weight, then the mask may shrink or stretch. So or patient is gaining weight, so it might not fit very well anymore. Then you need to either redo the mask to make sure that you have a well-fitted mask for every single fraction. Okay, another things that commonly be used for the head and neck is what is known as a bite block. So a bite block is like a mold that we use to give to the patient so that patient can bite into it and lash their teeth onto the block. Okay, so one of the advantage is we are using it so that there will be no build-up material on the patient's surface. Okay, but some of the disadvantage is because it will be inside the patient's mouth. So not all patients might tolerate having it inside their mouth for a long period of time, around 25 to 30 minutes. So there might be a gagging reflex on the patients. And because after like 10 or 15 fractions, you will start to see the late side effect, especially in the mouth area. So it might be quite painful for the patient to maintain the bite block inside the mouth with the late side effect already inside. Okay, now this what we have is we have a modern bite block system. So it is an optical tracking system that will verify the correct placement of fiducial markers within the bite block itself. So we actually position the fiducial markers in relation to the isocenter so that we will maintain the isocenter the same as the one that we have during the planning CT. Okay, so it will help to give a GUI or graphic user interface to see if there is any shift in patient position so that we will actually do it as what we have planned.